I try to summarize in the 20 minutes or so, reconducting you on a sort of clinical track, which could be the clinical problematics and the stressors for the application of non-invasive ventilation. These are my conflict of interests. And the first message may be that if you look at the current practice throughout the Europe and all over the world, at the end you may be surprised, realizing that indeed the concrete application of non-invasive ventilation pertains no more than 4% of all our ICU admissions. Despite that, a lot of people is indeed fond of the technique. I would like to start with some emblematic cases, as I mentioned. The first one can be a female with a chronic heart failure, 81 years, with high pressure at home and with acute cardiogenic pulmonary edema. As soon as he is admitted to the hospital, probably if she receives the non-invasive ventilation, may have a lower failure rate, and in these cases, the application of the non-invasive ventilation is extant. How does it work? Yesterday, Michael Quintal stressed how the increase of intrathoracic pressure, this is true for invasive and non-invasive ventilation, reduces the work of breathing by reducing the negative clear pressure and consequently the respiratory muscles oxygen demand, as well as reducing the right ventricular preload and left ventricular afterload, and consequently the cardiac oxygen demand. Which are the point of stress? As first, we have different forms of non-invasive ventilation. Can be pressure support or CPAP. That is, in principle, simpler. Do we have a real impact on outcome when we apply these techniques? And can I apply also in more risky patients? Let's show you the results of two large meta-analyses, one involving 16 studies and the other one 17 studies, published relatively a few years ago. And the first message is that as soon as you compare the non-invasive ventilation in terms of outcome and mortality respect to the conventional therapy, which means oxygen therapy and cardioactive drugs, indeed there is a clear-cut benefit for whatever would be the approach, the CPAP or non-invasive pressure ventilation, in comparison to the control. And this was true in both meta-analyses. And if you look at the need of endotracheal intubation, which means the success of the technique, the same is true. Comparing the non-invasive ventilation to the conventional therapy, there is a clear-cut benefit. No matter if you apply non-invasive ventilation through CPAP or a pressure support. Then the final message that was kept by the task force of the European Society of Cardiology, published in the European Heart Journal in 2005, concluded that the evidence of using CPAP, especially non-invasive ventilation and CPAP, over the standard medical treatment is indeed robust, and it can be applied as first-line intervention. CPAP or non-invasive positive pressure ventilation are indeed similar and can be applied without increasing risk in acute myocardial infarction. In practice, because the fact that CPAP is cheaper and simpler, is more extensively used. Non-invasive can be also considered as a first-line intervention in these cases. However, a few years ago came out another paper that was negative, where a large number of patients were compared by standard oxygen treatment, CPAP, and non-invasive ventilation, enrolling more than 1,000 patients, and having, however, I will do that later on, not very hypoxemic conditions. The final results of this study were negative because no difference by using CPAP or non-invasive positive pressure ventilation, as well as no difference in terms of probability of survival when you compare the standard oxygen therapy to any forms of non-invasive ventilation. However, if you look at the data into details, you can see that there are no difference in terms of short-term mortality, long-term mortality, and intubation rate. However, there is always an however, this study included only healthier patients. 9% of them did not complete the treatment. There was an important percentage of crossover. The criteria for endotracheal intubation were not objective. Sorry, and the mortality rate in this group of patients that was enrolled in the study was lower than that reported in the meta-analysis. And even more, these patients were not hypoxemic, because at admission they were hypoxemia, so-called hypoxemia, was as average something between 98 and 101 millimeters of mercury with a low intubation rate. So, which could be the messages? If I have to start an approach like this in these patients, I have to start early, presumably in the emergency department, with experienced staff, with an outcome that in general is good, with a rapid resolution, and I can transfer the patients in the ward. Change the scenario, another patient, totally different, younger, with severe condition, pneumonia, with in few terms, it's a patient with a RDS. So we have to move, this is another important message, to the ICU. And if I want to apply and want to approach these patients by non-invasive ventilation, there are a number of questions. Can I treat these patients with this technique? Can I improve his outcome or her outcome? Which one could be the best candidate? And by starting a trial, may I delay a necessary intubations causing harm? And which are the criteria that I have to take into consideration for endotracheal intubation? As first, physiologically, we can say that as soon as you apply non-invasive ventilation in comparison to the spontaneous breathing in these hypoxemic patients, mainly if you apply a combination of pressure support and PEEP, you may get a clear-cut improvement of gas exchanges in terms of PaO2, VO2, and PaCO2. And you are not able even to distinguish those patients who may be ventilated non-invasively to those who were received since the very beginning an endotracheal intubation. So it's effective. But even more, it's capable, this is data coming from the Laurent Brochard group, that is capable to reduce the work of breathing in terms of pressure time product and inspiratory effort that may be represented by, and inspiratory drive that may be represented by P01. And in terms of other outcome, mortality in some studies, certainly the reduction of endotracheal intubation, and namely reduction of complications that are in large part represented by severe sepsis and pneumonia. However, if you look at the real application of the technique in the real world, all those patients who had a de novo acute respiratory failure, which means acute hypoxemia and mostly acute lung injury, despite the constant increase on application of this technique over the years, having this pathology represent an increased risk for failure of non-invasive ventilation, as well as a lower PaO2, VO2. But even more, looking at the same package of data, the failure of non-invasive ventilation and together with immunosuppression and higher severity score represented a major risk factor for death in early NRES patients. But let's imagine the evolution of our patient. After the application of non-invasive ventilation, after 1 hour, the patient is still tachypneic, tachycardic, and hypoxemic with a persistence of a mild dyspnea. Then what to do? In my opinion, there is no hesitation. You should intubate these patients. Also because you have to keep in mind, as I mentioned before, that if you refer to the more severe categories of patients that may treat with this technique, the failure rate should be in mind in the real world, being something in between 40 and 60%. And so that these are tricky patients, probably having criteria coming from the evidence we have that those patients who do not improve PO2, VO2 over time, just for 1 hour of application of the technique, and those who are more severe, have indeed a higher risk of failure. And if you focus specifically on the patients who are RDS, you need to keep in mind that you have to choose the right candidate. Coming from the Ralph-Meyer group, there is, in my opinion, an important message. The study was negative, but tells us something very important. for the principle of application of non-invasive ventilation. Those patients who are in shock, those who have a higher failure rate and a higher SOFA score, which means organ failures, and those patients who are septic or more severe severity score on admission are not good candidates to receive non-invasive ventilation. Focusing on RDS, you can tell that you can achieve good results in the real world. This is a survey that was conducted in Italy and in Spain. And at the very end, despite the fact that the number of patients on RDS who received non-invasive ventilation was no more than 30%, there was a good improvement of gas exchanges with a relatively low failure rate and death rate for those who were successful, having a general mortality rate that did not exceed 27%, comparable to that one of the NIH trial. All those who failed in the first 24 hours prevalently, and again, looking at the combination of severity and lack of improvement over the first hour of application of non-invasive ventilation, those who had more severe, who did not improve, had a higher failure rate and consequently mortality rate. The story of the immunocompromised may be different. We have here more solid evidence. Those patients who received solid organ transplantation and developed in the postoperative phase an acute respiratory failure, they had a benefit by the application of non-invasive ventilation in terms of reduction of complication. And this was true also for patients affected by hematological malignancies, other immunosuppression, or ADS. Again, the complication was less, and the VAP was less. And if you apply the technique with another philosophy, the intention to prevent the admission to the ICU, this may be effective as well. The Marco Ranieri group showed, even though on a small group of patients, that as soon as you apply the CPAP outside the ICU in the world, in hematological patients who develop hypoxemia, at the end you may reduce consistently the ICU admissions, and you may also improve survival. These are small numbers, but the signal is strong. In a large survey that we conducted and is going to be published in print in the Critical Care Medicine on more than 1,300 patients, we could show that whole hematological patients with RDS and acute lung injury are ventilated with non-invasive ventilation for no more than 21% of them. And those who were successful had a lower death rate. Those who failed had indeed a high death rate. And by applying the propensity score in order to compensate the lack of randomization in this group, we could notice that non-invasive ventilation was indeed a protective factor for mortality. But at the same time, as soon as these patients developed the stroke or septic shock, for example, after the application of non-invasive ventilation, the risk of mortality was indeed higher than in the general population. Importantly and worrisome is that as soon as you look specifically to those patients who had a clear-cut diagnosis of acute lung injury and RDS, those patients who failed non-invasive ventilation and were subsequently intubated had indeed a higher failure rate in comparison to those who received the invasive mechanical ventilation since the very beginning. So a word of caution applicating this technique to these patients. Again, final messages: when to start early, where, always in the ICU, who, the personnel may be experienced, have to be very experienced. A nice skill is important. The outcome indeed is in part questionable because we do have a relatively slow resolution and a great risk of intratracheal intubation. However, as soon as you have the need of intubate the patient, do not delay, do not hesitate. And probably the best benefit is in the immunocompromised patient. Last sequence of slides: patient with COPD, patient who is acidotic because of the hypercapnia, and who has this condition on hospital admission. distressor. Do I have to intubate these patients who is acidotic? Shall I improve the outcome of these patients? Shall I treat these patients outside the ICU, or can I treat him in the ward? And if I apply this technique in the late phase of acute respiratory failure, is it effective or not? We have a consistent body of literature that shows that all those patients who have been approached by non-invasive ventilation had indeed 83% of success, high success rate. When we applied early, we have the best results, but the early means also just to have several messages coming from the literature on which could be the best pH for receiving non-invasive ventilation in these patients. And if you look at what we have from the literature, the Planck study published in The Lancet in the year 2000 tells us that as soon as you treat them in a very simple system outside the ICU in the ward, you may have indeed a very clear-cut improvement of pH and a very low failure rate in comparison to the conventional treatment. Interestingly, looking at the different studies published up to now, all those who received non-invasive ventilation in the ward were indeed less acidotic. And if the non-invasive ventilation was applied in the ICU, probably you may treat patients who were more severe. But even more interestingly, the skill counts, because if you look at the survey conducted by Annalisa Carlucci, again the Créteil, under the coordination of Laurent Brochard, she showed that during the first period, those patients who had a lower pH, 7.21, they were identified as those patients who were more prone to fail. But the same pH identified the patient in the subsequent period who were indeed successful. So as soon as you acquire competence in treating these patients, your outcome may improve. On the other hand, you may apply the technique also when the acute respiratory failure in the COPD is already established. And we conducted, together with Giorgio Conti, a study in patients who were initially treated in the emergency room, were transferred to the ward, developed again an acute respiratory failure, and they were admitted to the ICU. And these patients, these patients were not so many, 23 in one group and 26 in another one, were randomized to receive non-invasive ventilation or immediately invasive ventilation. And interestingly, you may see that those who received, non-invasive ventilation, but the standard treatment. And as soon as you received non-invasive ventilation, you were able to improve the PaCO2 and pH also when you applied the technique later. But the failure rate was higher with respect to the moment when it is possible to apply in early phases. Interestingly, if you look at the number of patients who required intubation, those who had indeed intubation had a higher severity score, a higher dyspnea score, and a number of invasive devices that was higher as well. However, looking at the long-term outcome of these patients, the number of patients who were subsequently readmitting in the following year were less in the group that received non-invasive ventilation and were subsequently discharged from the hospital in comparison to those who received a successful conventional treatment. And also the number of patients who had an oxygen dependent at home was indeed less. This is my conclusive slide, which could be the final messages looking at this category of patients. That may be better to apply early, because indeed if I apply in the late phases of the acute respiratory failure, may be successful, but in a less percentage in comparison to the early treatment. You may apply differently from the other category of patients, the hypoxemic, in the emergency room, in the ward, and in the ICU. You may also apply in a context where you have an experienced staff, but with less nurse, because the one-to-one is not always necessary, and indeed you can get a good outcome also in the later phase. Thank you.